Good evening, respected teachers and my colleagues. So, we're going ahead with two cases, a case series on patients with recurrent hypoglycemia. Is it really an insulinoma? 46-year-old male, diabetic since 15 years on oral hypoglycemic agents, visited the endocrinologist in view of recurrent symptomatic hypoglycemia. The hypoglycemic episodes persisted despite stopping oral hypoglycemic agents for a few weeks. So he was evaluated where a serum insulin and a serum peptide level was done. Serum insulin was significantly elevated, but the C-peptide level was within normal limits. So, the C-peptide was elevated. As insulin and C-peptide levels were elevated, he underwent a CECT abdomen. The CECT abdomen was normal. So with a strong suspicion, he then underwent a PET-CT gallium DOTA exindin 4 scan, which is suggestive of focal uptake in the head and proximal body of the pancreas. In view of the above findings, he underwent endoscopic ultrasound, which was suggestive of no obvious space-occupying lesion in the pancreatic parenchyma. Second case, a 32-year-old male, diabetic since 10 years, was again evaluated for recurrent hypoglycemia, where a fasting insulin level was 22, C-peptide level was 5.1, which was elevated. He underwent a CECT abdomen which showed diffuse moderate to severe hepatic steatosis but no focal lesion in the pancreas. Again, he underwent a PET-CT gallium DOTA exindin 4 scan, which was suggestive of focal uptake in the head, uncinate process, and distal body of pancreas. He underwent an endoscopic ultrasound, which was suggestive of a small 8x4 mm SOL near the head of the pancreas, adjacent to the portal vein. Pancreatic parenchyma was normal. Endoscopic fine needle aspiration from the peripancreatic SOL was showing predominantly acellular material, which is non-diagnostic.
So in these, both of these patients, I mean, this is where we stand. So should they be offered surgery straight away, or what should be done? Because CT or any other imaging does not show a focal lesion. Insulinomas are usually benign, single solitary lesions. But in these patients, when we do this extended scan, you find focal uptakes in multiple sites in the pancreas. So, what will be the surgical?
What are you telling? No, I didn't understand. Last sentence.
No, focal uptake in multiple sites in the pancreas. It's not one area.
It showed, you were telling it showed.
It showed. The PET exindin shows head and body. But when you do a EUS, you don't see a well circumscribed lesion. CT doesn't pick up a well circumscribed lesion. They are symptomatic with hypoglycemia still.
No, I think that is circumstantial evidence to biochemically and even Dodnak's hand. There's a lesion there. I don't know what is the efficacy of endo ultrasound to.
I agree.
There's an issue because when intra-op ultrasound is the thing which is. I mean, I don't know when you compare intra-op ultrasound and endo ultrasound, how can you compare those? But quite often, endo ultrasound is the one which will sort of localize more or less the lesion.
No, if it is focal, I agree that it's well circumcised that we are going to offer a surgery, like only the head or body or one site varies me. But when you see multiple sites of nodular uptake on this kind of scans, it's very little thought-provoking to say whether it is just insulinoma or it is just multifocal insulinoma.
See, actually, multifocal insulinoma is a rare thing. Actually,
exactly.
It will be a solitary lesion, and
so
quite often it will be the distal sort of pancreas. So when it's multiple, the thing of worrying.
So that is what is worrying. I mean, should we offer him a surgery, or what do we do about? How do we proceed with this? No, these were basically referred for EUS. I just picked up these two patients where I'm not sure what to do right now.
What about venous sampling? No, I don't know whether we are doing it or not. But these are the cases where we have to go for that. And we can isolate the site, and then intra-op we can, say the intra-op ultrasound.
Correct.
Because we have to have a justification to go for a surgery.
I agree. When that is done, when we don't find any lesion at all. So even
You know,
when
the
we
first
don't
case
do the
is not,
extended
first case
scan,
is showing only one area, second case is multiple area.
no, even the head and body. So when we
Yeah,
do,
first one was one only, no?
Have you ruled out nesdioblastosis?
sorry,
Nesdioblastosis, have you ruled out?
how do we rule out?
No.
No, unless I see something I can't sample.
See, if you see multiple lesion which are dotonic avid and the C peptides or insulin is raised, do we need to really sample those and then go for it, or directly we can go for the procedure? I mean, the planned surgery.
That's what. See, I mean, if it is like in multiple sites or it's a total pancreatectomy,
Yes.
that's what I want.
Yeah,
others to
in
confirm.
fact, I have a case capsule of total pancreatectomy being done. So if it's dotonic and symptomatic hypoglycemia, you see multiple lesions on dotonic, it cannot be anything else.
It's not a dot on NAC. Dot on, what they did because of, they thought of an insulinoma, they did an extended scan. We'll come to that. Just extended is specific. See, insulinomas don't express somatostatin receptors.
That's correct.
So the extended,
It
expressing it focuses on the GLP-1 agonist, and the insulinomas express GLP-1 so much. So it is quite sensitive to pick up insulinomas. So it's an extended 4 DOTA, if you were to say. I'm sorry, it's an extended 4 PET-CT.
What was the hypoglycemic clinical manifestation?
Is it more of a neuroglycopenic kind of a thing, where they become drowsy and they find hypoglycemic indexes. No seizures, but definitely they had drowsiness. They had low blood glucose levels. Exactly, I don't remember those details exactly, but basically referred after these things. Documented symptomatic hypoglycemia. Both these patients were diabetics, incidentally. So all these patients have been off their hypoglycemics or insulin, but still continue to be symptomatic hypoglycemia.
Sir, in the first case, actually the C-peptide was normal, right?
Yeah, 0.8 fasting level. Was.
Borderline.
But the ratio is, the blood sugar, the ratio was more than
I
0.3.
think, I think first line we should try diazoxides kind of stuff to see whether it is being controlled.
That is what right now they are on,
Okay.
but I just wanted to collect some ideas like what would the way,
See,
what would be the way forward.
Total pancreatectomy, I think, is a big kill actually. The thing of multiple insulinomas, I haven't come across either literature-wise or even in practice. Solitary, of course, quite often we see, and then ultrasound guided.
So usually enucleate.
Enucleated, and they become all right. I think we have to do some sort of a frozen and then on table, because going for a total pancreatectomy, we are converting one side to the another side, which will be, will develop brittle diabetes, and it's very. If you have to berry pick, you have to berry pick. You have multiple lesions, and which you can say intra ultrasound when
Suppose
you can.
it is negative, like I agree, that would be the plan.
Yeah.
Suppose it doesn't show anything, we give him that.
See, there was a time when you don't see anything, people used to distal pancreatectomy, because thinking that the whole insulin producing areas are in that area, but I think that's been given up once the intra ultrasound came into being. Now, if there's nothing else to do, once you've gone in, I would consider do a distal pancreatectomy, and see, because trying to do total pancreatectomy is too much of a disease we are creating is what my.
See, right. I think we'll just review that also.
See, basically, insulinoma, first you have to demonstrate that there is a biochemical abnormality. After that, you have to localize. When it comes to localization, I'm not sure about this particular scan, but generally the recommendation is not a DOTA scan, because as you said, it doesn't express somatostatin receptors. So the next option is to go for an endoscopic ultrasound. Ultrasound is the gold standard. But you are telling that your endoscopic ultrasound is not picking up insulin. That's a little unusual, and that brings Dr. Sendil's, whether it could be an blastosis.
What would you take from there?
I didn't do a contrast screen, so I don't know.
The thing of portal vein sampling, I don't know whether it's done at all, whether you have done any.
We have had
because
one patient
it's
like
more
this.
theoretical than.
No, so in one of these patients, one similar
Bhaskar, your
patient,
comments on this? How would you tackle the second one?
I asked what is the clinical manifestation of hypoglycemia? Suppose you have a patient that have refractory seizures and it's very life-threatening. Then you can take and if it's going to be an blastosis, then there is a role of total pancreatectomy. In fact, in a pediatric surgery, they do it.
correct. In the pediatrics,
But that's what I want to know. Suppose if it can
it's
be
not like
managed,
life-threatening seizures.
if it can be managed with a diazoxide and you can overcome, you can wait for some more time. No.
Total pancreatectomies. But what are the indications of total pancreatectomies apart from something like this? You've done in any case multiple
It's
incidents.
multifocal NETs,
NETs.
where we cannot very pick, where we cannot do a distal.
No, I'm asking if there is anything like what he is trying to ask, like multiple insulinomas. Have you ever seen one like that?
Yes, we have done the case capsule I've had is.
But have you done a total pancreatectomy thinking that this is what it is and then it turned out to be something
No,
else?
no, this is a situation, yeah, your point is without even knowing what the pathology is, I will not there is no, lesion in the CT, only biochemically we see raised insulin or hypoglycemic episodes. Yes, probably I will stop with distal pancreas if it is really indicated. Where we put all our efforts, no imaging have picked up anything, any lesion, probably I have not done that one. I am talking about lesions which are scattered all around where any of the partial pancreatectomies cannot be done. We have to resort to total no berry picking, no enucleation, distal median ripples. Then we have to
I
resort
agree
to
with you where you know you are going to do and where you are mentally tuned to go for total pancreatectomy. In this case, to judge and say that based on this sort of a scan to go for total pancreatectomy.
in spite of all the efforts to localize, still the patient continues to have hypoglycemic episodes. The textbook recommendation is distal pancreatectomy, which I personally now done, but for the younger members, probably this should be the answer where we should be trying and then doing a distal pancreas. The morbidity is much less compared to the Whipples. So we remove half of the pancreas thinking that there will be some improvement in the post-operative period. Sir, any one of us in the audience have come across such a situation where without any demonstrable lesion, we go just for the sake of the biochemical or symptomatic hypoglycemia. Have you done, sir?
Now this preoperatively is localized, we see a lesion, characterize it, then only go in.
I'm not talking about that, Radha.
Yeah.
What I'm saying is that yes, agreed. Where you have everything, you just go in, you operate. Yeah, that is perfect.
Yeah.
Even if it has to be
Blind
such
total
a morbid
pancreatectomy
surgery
is
like
a
total
no-no.
pancreatectomy.
Blind total pancreatectomy is no. How can you do a blind total pancreatectomy hoping that...
In the case only, if anything like that should be planned, it will be blind. In this case.
Probably we can do multiple biopsies.
No, I agree. Suppose it picks up, we are happy. Yeah. If it is not seen, then what do you do? Because I don't know.
Yeah. Proceed.
So,
Just a review of what we know. I mean, I just had to read a little bit, so I thought we'll share with you what we have seen.
performance characteristics of imaging modalities in insulinoma. So the imaging modalities that are used for localization are contrast-enhanced CT, a contrast-enhanced MRI, which is more sensitive than CT for this indication, endoscopic ultrasound, and a Dodanac PET CT. So some of the performance characteristics of imaging modalities in insulinoma, endoscopic ultrasound has the highest sensitivity of 93% as compared to the other two modalities, where the specificity of CT is high. But in the case series that was studied, endoscopic ultrasound was able to detect insulinoma in 50% of the patients with a negative CT and 70% of the patients with a negative MRI too. Somatostatin receptor expression in gastropancreatic neuroendocrine tumors. So the gastroenteropancreatic neuroendocrine neoplasms overexpress the somatostatin receptor subtype 2 at a higher density, that's 70 to 80% in the cases, except in benign insulinomas where the expression is lower. Glucagon-like peptide 1 receptors that are present in pancreas, blood vessels, stomach, or parafollicular C cells. Ruby et al. Have demonstrated that these receptors are overexpressed in benign insulinoma, which is the target for molecular imaging. So GLP-1 receptor expression in insulinoma, they are expressed at a higher density in benign insulinoma, that's 5 times as compared to the normal beta cells. A naturally occurring stable GLP-1 analog exists named as the exendin-4, which is the component of the Gila monster venom. It's a synthetic US FDA approved GLP-1 analog established for the treatment of type 2 diabetes by targeting the GLP-1 receptor. The other ways for localization is by selective angiography and calcium stimulation tests with hepatic vein sampling for insulin levels that can detect a tumor in about 60 to 80% of the cases respectively. So when intraarterial calcium is injected, over 20 seconds you see there is a significant rise in the insulin levels. The gastroduodenal artery, which is going to be the branch that's supplying, you'll see a significant uptake when the samples are taken. Exendin PET-CT performance characteristics in insulinoma. The sensitivity of the exendin PET-CT in localizing insulinoma is 75%. Comparison of various imaging modalities for localizing insulinoma. When an exendin-4 plus an MRI is done, the clinically relevant lesion specificity is about 100%. Similarly, when you do an exendin-4 PET-CT alone, even without an MRI, the relevant specificity is 100%. So, which means exendin-4 is more sensitive as compared to other investigations. Comparison for an exendin PET with contrast MRI, when we see it, the sensitivity range and the positive predictive value is about 100% to 99%. It's almost 100% when exendin scan. Could this be a multifocal insulinoma? Multifocal insulinoma. Insulinomas are usually small, single, benign, well circumscribed, evenly distributed throughout the pancreas. They can be about multifocal in less than 10%. However, when they are multifocal, a suspicion of MEN1 syndrome should be kept in mind. About 10% of them are metastatic at presentation. Endogenous hyperinsulinemic hypoglycemia. So, some of the etiological or the causes of postprandial hypoglycemia could be insulinoma, a non-insulinoma pancreatogenous hypoglycemic syndrome, post-surgery, autoimmunity, hereditary disorders like congenital hyperinsulinism, hereditary fructose intolerance, or factitious hypoglycemia. As Sir said, could this have been acidoblastosis? So the difference between insulinoma and acidoblastosis, fasting hypoglycemia is seen in insulinoma, and postprandial hypoglycemia will be characteristic of acidoblastosis. The age of onset, about 50 years, it's an elderly, and acidoblastosis is more in the pediatric age group. The incidence of insulinoma is more common. The C-peptide levels, however, will be high in both the cases, but insulinoma will be a unifocal, well-circumscribed mass lesion. 72-hour fasting is usually positive in insulinoma and negative in acidoblastosis. The gene mutations that have been associated are MEN1 in about 10% of the cases, which is multifocal, and GLUD1, GCK, and rarely menin gene. The treatment usually offered to insulinoma patients is enucleation, where for acidoblastosis is partial pancreatectomy. So the histological findings that we find in acidoblastosis is islet cell hypertrophy, increased nuclear size of the islet cells, and ductular insular complexes after insulin staining. So the drugs that we generally use are diazoxide, chlorothiazide, nifedipine, but diazoxide is most commonly used. You start at about 5 to 20 milligram per kg per day in divided doses. To summarize, insulinoma to be considered in differential diagnosis of recurrent hypoglycemia. Insulinoma is usually a solitary small and benign lesion. Localizing insulinoma in patients with a biochemical evidence of endogenous hyperinsulinism continues to be a challenge. Enucleation of benign insulinoma is preferred. Performance characteristics of various imaging modalities is reviewed. Exendin PET is very sensitive and specific for insulinoma. Non-insulinoma pancreatogenous hyperinsulinemic hypoglycemia, acidoblastosis, diffuse and focal form has been described. Pancreatic resection is preferred for these. Thank you.
What was done in both the cases?
They are only on medical treatment as of now. They are going to follow up. So we don't know what more. It depends on how they come back. So if they continue to be symptomatic, that's when where my worry is. What do I offer?
Pyramid.
Diabetic, sir. Yes, sir. Yes, sir. That was one of the questions that wanted to be addressed. There is no literature on the false positivity regarding this.
After maybe stopping, because these are on the gene, whether the drug binds there.
Yes, sir.
See if you are getting the same thing. Suppose you are getting this color in a different place, then you know it's cancer.
What is the cost of this PET scan?
No, I'm not
And is it available in Chennai? Fine, I think we'll move on to the, thank you, thanks.